Good afternoon and welcome to the webinar, Leveraging Innovative Technologies to Combat Healthcare Fraud. I'm Richard Moore. I'm a state senator from Massachusetts and immediate past president of the National Conference of State Legislatures. I currently serve as co-chair of the NCSL Foundation for State Legislatures, Transforming Healthcare Through Technology Partners Project, which is co-sponsoring this webinar. Senator Kemp Hannon from New York, who also co-chairs this project, will join me in moderating our program today. Over the last year, the Transforming Healthcare Project has explored a variety of ways in which technology is advancing and improving healthcare delivery in the states. Today in this webinar, we'll hear about successful strategies to use technology to combat fraud and abuse in healthcare, providing potential cost savings for the states. Speakers will discuss the use of sophisticated IT systems and increased information sharing to identify abuses and reduce losses. We appreciate the support of the private sector partners who have sponsored the Transforming Healthcare Project over the last year and a half. They are AT&T, MDON, ESRI or ESRI, the National Cable and Telecommunications Association, Philips, and Reed Elsevier. And today's program includes speakers from two of the firms who are sponsoring our project, MDON and LexisNexis. We'll also hear from the Chief Program Administrator of the Program Integrity Unit for Arkansas's Division of Medical Services. We encourage you to submit questions for the speakers, and we'll respond to them at the conclusion of all the speakers' remarks. Our first speaker is Kelly Garvanian, a solutions consultant with MDON Payment Integrity Solutions in Illinois. With more than 30 years' experience in the healthcare industry, Ms. Garvanian is an accredited healthcare fraud investigator, a certified fraud examiner, and a founding member of the Midwest Anti-Fraud Insurance Association. She's a former chairperson of the National Healthcare Anti-Fraud Association and has served on its executive committee and institute board. Ms. Garvanian is active in all national anti-fraud associations, has spoken at numerous conferences and educational seminars, and is a recognized authority on healthcare fraud. She's a member of the International and National Association of Special Investigation Units. Ms. Garvanian acts as MDON's in-house expert on healthcare fraud for health, life, dental, and disability insurance. Before joining MDON, Ms. Garvanian served as Vice President of Operations and Client Services at the Sentinel Group, which is now MDON Payment Integrity Solutions. Kelly?
Thank you, Senator Moore. And thank you, participants. I thought it would be good to begin with a little bit about MDON and why MDON is in the program integrity business at this point. You may have heard of MDON as a clearinghouse, and the slide that you see right now shows MDON's positioning within the country on government side, public side, commercial, Department of Defense, pushing together and connecting together providers, consumers, payers, and pharmacies. And MDON does about 48 to 50% of all healthcare transactions in the country go through MDON. And MDON used to be owned by WebMD, but now is privately held. So I wanted to kind of give you a little bit of background. Because of this connectivity that MDON does have, we feel that we're well positioned between providers and payers to actually put some analytics within that stream in order to prepayment identify fraud, waste, and abuse before the claims are actually paid. On the post-pay side as well, when payers are actually sending checks and explanation of benefits to members as well as providers, there is that opportunity because of MDON's solution at that point to also be able to do this in a post-payment mode, although the next few minutes that I've got to address you, I'd like to talk about fraud, waste, and abuse in terms of a prepayment approach. So let's talk a little bit about some of the concerns. 48 states are forecasted to have declining revenues in 2012. I've got a couple of quotes on the next slide. increasing Medicaid populations, a prevalence in fraudulent activities, the high cost of actually recovering pay and chase fraud dollars. You will hear pay and chase mentioned a couple of times. That is, after a claim has been paid, going after those particular providers of service and asking for the money back. Continued staff reductions at the state level, less public visibility, and cutback office administration versus education and other direct services. And regulations which don't allow for dollars to be saved under fraud detection in order to fund the programs themselves. I've listed a couple quotes here. One is from Ted Clark, the director from the Kansas Fraud Bureau and the working chair of the Anti-Fraud Committee of the NAIC. And he says, and I quote, "You would think that when the economy is tough and fraud by opportunists is increasing, that the states would devote more resources to fraud, but that isn't happening." Chuck Gregory, the head of the fraud unit in the state of Arizona, "There's a lot of fraud going on, and not having manpower is a very big problem. On a lot of cases we're just putting out fires and working off case referrals that are coming in. The rest are going by the wayside." What you see in front of you now is CMS's direction from Dr. Budetti's April 14th spring meeting. On the left side, you will see where we are with the current state. We're working in a pay-and-chase environment, kind of a one-size-fits-all, very old legacy processes, more inward-focused communication, government-centric, and standalone payment integrity, program integrity programs. With the future state going to prevention and detection, risk-based approaches, more innovation, being transparent and accountable to members as well as providers and constituents, engage public-private partnerships in order to maximize what's happening on the commercial side, and coordinated and integrated program integrity programs. I thought this slide was very interesting because you see and you hear a lot about credit card fraud and identity theft all over television and the media. And these particular silos show you that credit card fraud is about $788 million. Identity theft is about $52 billion in lost expenses. But those are like nothing compared to the $240 billion that are lost to healthcare fraud. So when you look at this particular graph, it is alarming to think that more emphasis and concentration is not put on healthcare fraud, waste, and abuse. So everybody knows, this is a huge problem. What I will leave this up so that you can read it, but what I want to concentrate on is the bold. By taking this seriously, an administration can save, 10% or even maybe 20%. But to do that, you're going to have to spend 1 or 2, which the point of this is obviously that the return on the investment is going to be not 10% or 20, but by a factor of 10 or 20. And I think that's really important in understanding where these budget cuts are occurring and how saving the money on the program integrity can actually fund other areas within your state. The comprehensive program in 2012 is to efficiently and accurately pay only those claims which are valid, removing the wasted dollars in the system. And you can really only do that by having this in a prepayment approach. In a post-pay, pay-and-chase model, which I described a little bit above, the return on that is typically anywhere from 3 to 13 cents on the dollar. So that's, $1,000 went out the door and you're trying to get money back. It usually ends up being some sort of a settlement with the physician and you're going to get 3 to 13%. Versus that $1,000 claim that comes in on the front end is possibly submitted by a provider who doesn't have a license to perform or is billing for services not rendered. That's $1,000 actually saved from the state's budget if you were to perform that in a prepayment approach. MDN has several safety nets. We believe, and it's my experience in my 30 years of doing this, that there's not just one solution to fraud, waste, and abuse. There are a number of different solutions that need to be taking place at the same time in order to assure that you have a comprehensive, holistic approach to fraud, waste, and abuse. You'll see the first is provider data validation. This is also going to be a requirement by CMS in 2014, looking for licensure, sanctions, dead doctors, doctors who are buying identities from other doctors, that sort of, even bad addresses, quite frankly. Clinical integrity is looking for those source edits that are automated edits in order to identify bundled claims, duplicate claims, but very aggressively looking at history in order to make sure that you're doing that at the front end. There are rules-based approaches. I will get into these as we go a little bit further, deeper down. Predictive analytics, which is the buzzword right now, actual investigations, and then there is a place for the RACs on the recovery audit for those areas that could be policy guidelines or reimbursements rates and policies. I bring this to your attention. This is a real report card. That's what we call them. This is a physician in Indiana, an ear, nose, and throat physician, and the blue circles represent his aberrance based on his peer group performance. So all of the red bars are bad. I'd like to direct your attention to the bottom. This particular physician is doing 11 and a half procedures per patient compared to his entire peer group at 0.6. This doesn't mean he's bad. He could be in a rural area. He could be a specialist. But he definitely is an aberrance that needs to be identified. This particular gentleman is Dr. Mark Weinberger. He was on 60 Minutes on 2020, America's Most Wanted, and just got indicted by the FBI maybe about a year ago. But I wanted to show you this real report card from him as just an example of what a rules-based approach would show you. There are also what you don't know. So if you look above the iceberg, that's what you know. So we know things are happening in durable medical equipment, for example, but what's happening underneath the iceberg and underneath the waterline is what we really are looking for in terms of predictive analytics. Predictive analytics are using certain statistical models that need deep data warehouses in order to reduce false positives and be able to bring true positives up to par. These are a couple different slides and examples of what's being used with statistical modeling, predicting normal behavior versus not normal. This is normal behavior based on a peer group, and then providers and patterns in order to monitor those activities and identify those before the claims are actually paid. I've got a couple more slides. I'm going to give you a quick example on durable medical equipment. This is one of the hot frauds right now. You'll see all the different examples. Why is DME so high right now? Because they're high-cost items, because there's a high percentage, obviously, by seniors, with the senior population growing as quickly as it is. There is a lack in every state across the country, as well as federally, of professional licensing requirements. Anybody can open something and start selling adult diapers. You rely on patient awareness and cooperation in order to show this, as well as overutilization and miscellaneous of durable medical equipment codes. Here are some of the scenarios that fall into durable medical equipment. A couple of these, there's big provider kickbacks happening. I will not hit on each one of these. A lot of these patients are offered just a free health consult. Sometimes these are done in senior centers. And during the office visits, they're sent home with equipment they didn't need or request. But at that time, those providers have their insurance information, so they are just submitting those claims left and right. Suppliers are delaying pickup after a member either passes away or no longer needs it, and continue to bill for longer periods of time. So with CMS's direction, as in the slide I showed you and the third slide above, MDN actually has all 6 of these particular competencies covered. With respect to pay and chase, because we do it in a prepayment mode for the prevention and detection, we do use a risk-based approach. We believe we're very innovative in the way we do our data mining as well as our partners. We are 100% transparent, accountable. We're engaged in both private and public side. And what can you as legislators do? We would like you to ensure that you have adequate legislation in place to address these problems. I mean, fraud is not going away, and fight fraud first is what we would like the message for you to send to your constituents. And consider a total population approach, as well as understand that cutting these budgets is really a blank check for those fraudsters to take advantage of those situations. At this point, I would like to turn the floor over back to Senator Moore.
Well, thank you, Mrs. Gravanian. This is Senator Kemp Hannon.
Oh, sorry.
No, that's all right. He passed the gavel to me. I'm co-chair of the Transforming Healthcare Through Technology project, and I have the privilege of introducing our next speaker, Kelly Mosbaugh, who is Director of State Government Healthcare with LexisNexis Risk Solutions in Florida. Ms. Mosbaugh works with government health agencies to identify opportunities where information-rich analytic tools can be leveraged to address the key challenges in health information exchange, fraud, waste and abuse, and identity management. Prior to working at LexisNexis, Ms. Mosbaugh was Senior Vice President of Informed Decisions, a Tampa, Florida-based healthcare solutions company. She also managed the operational development of the KatrinaHealth.org portal, a public-private initiative created under the leadership of the Office of National Coordination for Health Information Technology. She has over 10 years' experience working with government healthcare and information technology programs and holds a master's degree in public health from the University of South Florida. Ms. Mosbaugh?
Thank you, Senator Hannon. I appreciate the introduction and the opportunity to speak to everyone today. You heard at the beginning, Reed Elsevier is supportive of NCSL, and LexisNexis is part of the Reed Elsevier family. And for any of you that are recognizing that name, LexisNexis, it is the LexisNexis that you're familiar with if you've experienced the legal side of the business. I actually work with the LexisNexis Risk Solutions group, and so you'll be learning more about what we do through the presentation. But just to give you a little background, I'm the Director of State Government Healthcare, again, in the LexisNexis Risk Solutions group. I wanted to kind of start today by talking about fraud in general terms. And I like to show this cartoon because it does a lot of things at one time. The fat bag of cash that you see walking down the street so innocently says Medicare, which is a federal program, but you just change the name to Medicaid. You can change the name to any state social service program, anywhere where you have a large portion of a budget supporting different activities and services, you have risk of fraud. And the other thing I like about this picture is that you see that it says Miami over there in the dark corridor, and that's true, right? But Florida often is the leader in fraud activities, or so it seems, and then also those individuals, those dark, shadowy characters. They're key because that's really who's committing the fraud through a variety of different schemes and ways they manipulate the system. And often those people will be engaged together, and they could be the same people. And the fraud that they're committing in healthcare, they could very easily be committing in several different industries. So while that picture kind of starts to lay out the picture of why this is such an area ripe for fraud, it doesn't really go into the complexity of what we're dealing with for fraud. So I pull out a couple of articles, and you know this continues over time, regardless of what we put in place. You see things in these articles about paying for care to dead people, widespread kickbacks. There's a recent one just from this month where an unlicensed dentist was charged with stealing more than $20 million in dental benefits but he was using a hidden ownership in a string of Connecticut clinics. Again, these examples really bring out the complexity, but also that it's widespread. No one place is dealing with this. This last article is actually showing a group of gangsters that were operating from New York to Los Angeles. And you see things like giant identity theft ring, racketeering, money laundering, bank fraud. So with the complexity, this is where you hear a lot of times that we need to have these comprehensive or even multi-layered approaches. There's not going to be the silver bullet that takes care of all this and says that we're going to start to save the 10 or 20% that we believe we're losing in fraud in healthcare. If we focus down on one aspect of this, and I saw this in some previous slides about identity theft, healthcare fraud is broad. It has a lot of different places that it occurs. And if you want to look even specifically at some of these things that underlie it, medical identity theft is lucrative. Regular identity theft is a problem for all of us, but then again, medical identity theft becomes the same thing. We're all vulnerable. And it's because of these things. You see the 10 times the difference in what somebody can gather in value. The regular identity theft, they may get away with $2,000. Medical identity theft, they're getting away with $20,000. I've heard from multiple states dealing with stolen Medicaid cards. $1 for a Social Security card, medical identity information can go for $50. The World Privacy Forum started to track medical identity theft incidents, and I bring this up to show you again that no area is immune to these types of individuals that are committing this type of fraud. It occurs in a variety of ways. Some of the examples I showed you from the articles look at large-scale organized crime and how are we going to tackle that versus an individual's information that may be stolen. And then lastly, someone who decides to let their friend or neighbor borrow their card, or someone decides they're going to borrow the card from that friend or family to receive medical services. All of those would be considered under medical identity theft and fraud. Improper payments being paid out from state programs of particular interest, right, as taxpayers, and in particularly vulnerable populations of people who need those services that are now finding that there isn't enough to go around to support. So there's several key challenges. Look at the complexity of the fraud and how widespread it is, but we're also going through a major transformation in healthcare. And with that, we're having more people enrolling, and we're trying to move things into more efficient processes. And to do that, you want to leverage technologies and an electronic means to either enroll people, to help provide services to people in this way. So with this kind of transformation, we're having more regulations put in place, and subsequent to all of this is more fraud risk. And so what those things are is losses in money, but also the reputational damage that can occur when fraud goes undetected in some level, and then also when we learn of how it occurs. Then also there's the risk with regulatory compliance fines. Are we all doing enough to put the protections and ensure the systems are working at their optimal performance? So one of the goal of the webinar is to really look at innovative ways that we can start to impact and mitigate the losses that we have due to fraud. And part of that is transforming the general paradigm that we have for pay and chase. So today, it's really a post-payment fight. And not in all cases. There are several groups that are trying to move ahead and be more proactive. But basically, it's a paper-based system for enrollment, and then after people are enrolled, we're using what's referred to as data mining techniques or analysis to look at all of the payments and look for trends. Where are things spiking? Where are there potential problems? Once it's identified and investigated and determined, yes, that was fraud, we need to get the money back. Well, if we're talking about those shady individuals standing in the corner, many of them are gone. So that's the inefficiency in trying to collect those dollars. If we believe there's $100,000 in fraud somewhere, is it realistic to expect we get 100% of that back? No, not at all. Can we get 50% of it back? 30%. That amount will vary. So the better approach is to start to move the fraud the fraud detection to prevention. And there's a couple of successful approaches in other industries that really are starting to be looked at in healthcare and trying to understand how they can be integrated. And those two that I'm going to focus on are the identity proofing and the predictive claims analytics. And in both of these cases, it requires a greater focus on the individuals in these programs, the overall participants, the patients or the beneficiaries that are receiving the services. Are they who they claim to be, and should they be receiving those services, as well as the providers. A lot of that fraud that I talked about at the beginning is because there's an insider in healthcare who's helping the fraudsters determine how to get through the gaps and the loopholes in the system. So you need to identify, are these providers that are participating legitimate, and do they pose any type of potential risk? Ways that you do this, particularly the identity proofing, is by looking to external data. And when you look at this data, and it's on this slide, it's showing you on the right that there's several other industries that utilize this information to help with their own fraud prevention and detection, such as the financial market, collections, legal, other government agencies. And what the data and the linking and the analytics is doing that a state program would not have to do on their own is answering the questions of who are these individuals, where are they, right? So I'm Kathy Mosbaugh, but that's my married name. Who was I previously? And if I'm enrolling into a Medicaid program, was I convicted of fraud under my maiden name? And are we sure that my records are matching? Because as a person committing fraud, I'm not going to just disclose that I was previously convicted. These are the types of information that you can get by looking to public records information and data. And this is where LexisNexis focuses, finding those records, and then more importantly, using algorithms and analytics to link them together appropriately, so you can understand the full profile of the person, whether they're telling you that they've committed fraud or not. And it's when you take the data, which is really what I'm showing on the left-hand side, and you link it all down to that little blue circle. When you have this type of information, it can be leveraged in a variety of ways. It can be used up front in the enrollment process as somebody starts to apply, maybe in a new online system. It works even in a paper-based system, but you can start to say, they told me they live at all these addresses. I can verify that. The provider failed to mention that their license was revoked last year, that they were excluded from the federal government participation. That type of information can feed into the enrollment process, as well as a lot of the analytics that you want to do in the back end to look for potential fraud. Once you have this information, I wanted to give you some examples of what you find when you start to look at different state programs. So this was actually working with a state Medicaid program to layer in identity information. And what it found is that 2% of the beneficiaries actually had a primary address in another state. So if you consider the state where you are, and 2% of the people that you're paying for today may not be eligible for those services. A little more than 0.5% were deceased, and 2% of the adults were presented with severe identity fraud risk, which we see that this can be a very lucrative form of fraud to commit by individuals. Also looking at the providers and working with a state, we were helped to identify that 1% of the providers were actually deceased, 1.7% were sanctioned, and even a few providers were incarcerated. And there's a variety of reasons that you come up with these types of statistics in a state program. Part of it goes back to really being able to link public records data appropriately to an individual. This gets into a conversation of how to manage large volumes of data, and this is becoming a new and exciting area where states will be able to leverage big data that other groups are doing and the outcomes of that information to successfully enhance the current progress, right? So you don't have to go and build all of these things and understand how to link public records. That can be done for you, and then the results provided over. besides looking at the individuals, the other thing is that you can start to understand how an individual is associated with other businesses or individuals who may be participating in state programs. So in this example, the yellow box indicates an individual who's actually convicted of fraud, and the pink represents their business associates, the blue, the relatives, the green, business affiliations. And you need to look at the web that gets created around that, because there's various levels of the individual who committed fraud may own other businesses, either with relatives or just business associates. And that's what we saw in that recent conviction of the dentist who had stolen $20 million in dental benefits. If somebody already is convicted of a crime, that is a high indicator of risk for committing fraud again. All of that I've shown you about, the individuals and that type of information that can actually be brought in to current processes is another layer that feeds into the second innovation that I wanted to talk about today for state programs, and that's really prepayment predictive modeling. What that means is really moving that analysis that occurs after someone gets paid today up to prepayment or before it goes out the door. And the way you do that is you have to make a prediction. If I have 1,000 claims that we have to pay today, and we're, as an industry, we're looking at 10% we say is fraud in a year, well, which 10% of those 1,000 do I think is fraud? And you do this when you look at this picture that I'm showing you. It's just a variety of statistical analysis that feed into what's called a model. And that model will start to help predict which of those 1,000 or 10,000 or however many have to get paid that you need to look at more closely before you pay it. And then you layer in the identity information, which helps refine, I'm correct when I say this one has the highest risk of fraud, look at that one. So to give you an example, if you look at these three green boxes, the first one is showing you that if we did nothing and we just paid claims today, fraud is hidden, right? You're not even going to try and find it. There's a first step where you can put in a rule which says, is this person supposed to receive services, and they have submitted a claim as a patient, and they're the right age, and other things that I know. I can check those. We'll catch some fraud in that way. But then predictive modeling starts to look at all of these things that I'm not looking for, but are a potential prediction of fraud. That's what I need to consider. So you start to refine that information, and you score those 1,000 claims. The one that has the highest suspicion, that's the one that you need to hold on to, do a little investigation, and then decide if it gets paid. So that's not necessarily creating a whole new system, but it's taking some of those resources from the back end and starting to move them to the front end. But you do need additional technology and tools to make that work appropriately. Give you a quick example of the power of layering in this additional data. This is an insurer that found 7 claims that they thought were collusion, this organized fraud. Each of the little A's is a different payment that was going out the door. They were able to connect 2 of them just by their own data. When we layered in the additional data and went out 2 additional degrees, we were able to show that there were actually 2 families involved, all connected in some way, and that, yes, the 7 claims were related, plus links to 11 more. So it's when you support the use of these types of tools where we get better at not only detecting but preventing the fraud. So I just wanted to leave you with, where do you get started with moving some of these things ahead? And a few ways that you can do that, what I've talked about in this presentation, is identity proofing and verifying individuals that are enrolling, as well as the providers, and then supporting prepayment predictive modeling for claims processing. I also just wanted to highlight that verifying individuals becomes important for all of the things that are being transformed in healthcare. Not just Medicaid, but it's also health insurance exchanges that are enrolling individuals, as well as health information exchanges for the providers and the patients that may be participating. So with that, I want to thank you very much for your time, and I look forward to the questions. I'll turn the floor back over.
Thank you, Ms. Misbah. We could really go right now to the questions, and There's been some of them submitted during the course of your talk and Ms. Gavarian's talk, one of which was, I think, the most interesting, is that do states rely on the private sector to engage in fraud detection, or do any of the states have their own public governmental entities doing all of this? And maybe both of our speakers could address it.
This is Kelly Garvanian. I can start. It is a good question. I think what we're finding is there's a combination of both. Because of the budget cuts and the lack of resources, yet the increase of what needs to be done with respect to fraud, waste, and abuse investigations and program integrity, they're looking at external vendors to provide any incremental lift or any incremental additional analytics or case leads or anything like that that can really have an impact on the state. Again, this is not just what you're seeing and what I'm explaining on the public side is really not that different than the private side as well. The same kind of resource restraints, budget cuts, those kinds of things. In a contingency model, more and more states are looking at outsourcing specifically the analytics so that they can point their investigations and their resources in the right direction. Kathy, I don't know if you want to add to that.
Thanks, Kelly. I agree with you as far as, states, it's not that different, right? They may have, depending on the state, their own resources to do things. Most of the conversations I'm having, states are looking for whatever they can automate, whatever that they can do better by outsourcing that. And so that really goes back to who have they been able to bring on their staff and how much are they supported with the tools that they need to get things done. Budget plays into that along with a variety of other factors. So you may find a combination of, doing a baseline analytics and then sending the rest of it out for something more. But I would say overall, it looks more to looking to the outside, to understanding the technologies rather than trying to recreate it, and doing it in a way that would be much more efficient than you could using state resources.
What would you think is the hottest area right now that the fraud is occurring? I mean, you've gone the whole range of different types of Medicaid endeavors here, and how does one focus? If you're a policymaker in a state, what areas should be looking at and trying to direct, either if you're in the executive or legislative, direct your attention and resources to?
Kelly, I'll
go ahead.
Yeah. Thanks. In general, I would say it's things that are proactive and prepayment. But with that, I say that post-payment is an important piece to understand because you need to know the fraud as it's occurring today to be able to put different controls up front that improve the overall efficiency. So it is a difficult task to sift through it because I know for every state they're being bombarded with individuals bringing one great idea after another. I think if you ask yourself, is this one thing that I'm considering helping move us to more of a proactive, preventive model, then that would help guide the decisions on where to get started.
Yeah, I would agree with that in moving the prepayment. I wasn't sure if the question was, what are the kinds of frauds? But I did hear the question asked, what as legislators can you do or what should you be looking for? Fraud shifts constantly. If right now the focus is on durable medical equipment and IV infusion, which I'm sure you've all heard a lot about, 2 years ago it was the sweaty palms in California. 15, 20 years ago it was psychiatric claims and behavioral and mental health. So a lot of statutes have been put in place that address these as the frauds occur. But I totally agree with Kathy in looking at a prepayment approach and concentrating those efforts in the analytics and the data drill down and the provider verification and validation, which is very, very big. In terms of even state statutes with respect to penalties for providers that are actually doing fraudulent behavior.
Well, you've mentioned several times and the prepayment analytics. And that would seem to me one of the cutting-edge types of fraud detection, since so much of government is post-payment audits, looking what's gone out the door. Is there a way of trying to quantify how much the prepayment analytics needs to be done?
Well, I can tell you from an MDN perspective, this is Kelly Garvanian again. I quoted earlier a 3 to 13% recovery, which is pretty industry standard in terms of surveys that have been done in post-pay environments. I mean, if you're happy with 3 to 13% on your dollar, which is where most are today, I mean, I just don't think that's good enough. If we get the providers and we're transparent with these providers of service, let's be honest with each other. A very, very small number of providers are actually billing fraudulent. There's a lot of waste. There's a lot of abuse. But for the million providers, I mean, we're probably talking less than, half of 1% that are actually causing all this noise and causing these dollars. It's not to be ignored. But if we have the other 99.5% on our side from the state, that yes, we want to aggressively go after this and we're willing to do what it takes to prove that the services we rendered were actually performed, then I think that says a lot for moving to a prepayment approach.
And I would say on the identity verification side of this too, I know we did talk a lot about the prepayment, and I would agree with Kelly. The numbers are going to vary, and you have to determine what's most valuable to you. On the identity, there have been studies looking at what kind of return you get by using different tools to identify individuals who may have received improper payments. There is a report going as high as 8 to 1 return on investment for using tools and then identifying individuals that should not have received services. It depends on where you're implementing it, and again, what your costs are, what you're starting with. Every state is completely different, and what solutions you may have in place, you may be able to put from there versus wanting to start over and put in a full system. So, depending on where you are, I would say that there is success. It's difficult to say what would it, is there a hard number that everyone would receive?
Yeah. Well, actually, I think one of the earlier questions on the email was what was the $240 billion in healthcare fraud number representing, all healthcare or just Medicaid? I think, Kelly, you had brought this $240 billion number up.
Yes, that is across both public and private. It is not just one particular entity. Obviously, it changes from state to state, and even from in the commercial side, from payer to payer. But that is an all-encompassing number for all healthcare expenditures in the United States.
And Kelly, to your point on that, the all-encompassing number, you do have to consider that many state Medicaid programs are moving to managed care. So, the fraud is occurring in both. And while there is the belief is held that managed care does a better job with fraud, it still occurs. So for a state program who's shifting in this way, they have to think about how are they going to have oversight and insight, I guess, into the prevention measures for fraud to still occur in the Medicaid managed care environment.
That's a great point. So when you look at a managed care, even if it's a capitated HMO type of a scenario, rather than looking at overutilization of services, you may be looking at underutilization of services, and that then becomes a quality of care issue. So absolutely, that's a great point, Kathy.
Anyone have any idea if any of the states have actually identified savings going through any of these types of programs?
For the prepayment predictive analytics, I'm not aware of any published savings because it is fairly new. I've seen several states put out RFIs looking to learn more about the solutions and then evaluating how they'd be able to fit them into their current processes.
And there's another question about, does anybody in any of the states listed their actual fraud endeavors? I think what both of these questions reflect is the need in a given state by policymakers to look to someplace else to see what works. There's a lot of folks who will come before us and say, hey, I have a great idea, I have a great system, I have a great product, and you're looking for some outside indicia as to what may have worked in another state. And to the extent you have that information, it would, I think, be extraordinarily valuable to all of the listeners.
Yeah, this is Kelly. I mean, we get, like Kathy mentioned, we do get a lot of requests through RFIs. And my experience in speaking to state legislators, senators, and your aides is tell us what works anywhere, and then how can we make that work here? And the best example probably is going to come from the commercial side. So that's kind of the model that we've been proposing, as is Dr. Budetti, quite honestly, in his CMS endeavors. Moving towards a prepayment approach that has multiple safety nets, that is doing just about everything it can in terms of making sure that those true positives are actually being stepped ahead of time with the cooperation of the providers. So I think modeling, any state that can model somewhat, and even if it's modified, but model what's happening on the commercial side.
Yeah, but that's the trouble with the commercial side is they may tell you on a confidential basis, but given the fact they're in a competitive marketplace, they tend to treat their processes on a proprietary basis. Even though each of the commercial plans, say here in New York, have to have their own fraud detection unit. And some of them do a very good job and have told me some of the very good things they do. But it's very hard to take that and then translate that into the public sector because it's proprietary.
So I think that's where you can take advantage of the vendors such as Lexis and MDN and other. I'm serious, because we're working with, and Kathy would probably agree, we're working with both commercial and government, entities. So we would like to provide the best practices that we know and make those recommendations to you. I mean, Kathy, go ahead, jump in.
Well, for the prepayment predictive analytics, it's been used in different ways. Predictive modeling has been used a lot in predicting health outcomes, who's more likely to become sicker over time, and extrapolate that. Also kind of adjacent to that in this conversation, Senator Hannan, is that property and casualty insurance has used predictive analytics for quite some time. And fraud due to fake accidents and the medical bills that go along with that has been prevalent in that industry for quite some time. So if it can be leveraged, and it's kind of why I save it for the end, it can't always be leveraged to, look at property and casualty for healthcare, but there is the reality that they spent many years identifying the ways to integrate in prepayment predictive analytics, and they do that successfully today within that industry. And also probably similar is the fact that they're dealing with medical claims. The individual claiming that they have a neck injury and have to go to the doctor and have the x-rays and the CT scans, and everyone who may be involved in this type of fraud. So there is that industry that can be looked to as well for supporting this type of innovation in a state Medicaid program. Okay.
Well, I think we're getting to the end of the time. So I just wanted to give a chance to Senator Moore, if he wants to come back on and talk, finish off. But I also wanted to note that this webinar will be available within a week on the website for the NCSL Transforming Healthcare Through Technology website, so that if you want to recommend this to others, please feel free. I find that the descriptions that Kelly and Kathy have provided of the type of detection systems are really extraordinary and I think well done. We've just gone through here in New York, not on fraud, but on pharmaceutical opioid abuse, a very intensive, long debate, and the construction of databases, reporting systems, the interaction between pharmacy, doctor, and user, along with integrating it through the different fraud detection agencies we have in the state, is very complicated, and what you have done in making this a very broad presentation, I think, is going to be very useful for all. So I think we've addressed most of the questions that have been submitted up to now, and so Senator Moore, are you still with us?
I'm with you.
I'll let you give the closing remarks, and maybe you want to just even give a pitch about your Massachusetts experiments in healthcare.
Well, that would take too long to be on the webinar, but nevertheless, I do want to thank our speakers for their excellent presentations. I certainly have learned a good deal and now have a better idea of areas that we need to, on which we need to focus to make sure that we don't just get that 3 to 13% recovery, but to try to prevent the losses in the first place. I think both our speakers provided some very valuable information, and certainly have given me, and I hope those on the webinar, a number of great ideas to take home and explore with our respective states. For more information about NCSL's Transforming Healthcare Through Technology project, I'd encourage you to see the NCSL website that's listed on this page. The project will hold sessions on mobile health and telemedicine at the NCSL Legislative Summit this August, the 6th through 9th of August in Chicago. NCSL has also provided additional information about Medicaid fraud and abuse. This slide provides more information and NCSL resources on that topic. Thank you to all who've been part of this webinar and for attending the program. You might want to alert others to the fact that within another week they can access it as well if you thought this was helpful. Thank you for participating.